Hello, everyone. My name's Nick Smith. I'm currently fourth-year cardiology and critical care medicine fellow and chief fellow at the Johns Hopkins Hospital. I'm excited to be here today to discuss the inotrope versus placebo therapy for cardiogenic shock, capital DOREMI 2 trial. And so I'm happy everybody can be here.
Hi, everyone. My name is Pooja, and I'm a third-year cardiology fellow and CardioNerds ambassador at OHSU, currently applying for advanced heart failure. I'm so excited to be part of this multidisciplinary discussion. Dr. Benjamin Hibbert is an interventional cardiologist and assistant professor in the Department of Medicine at the University of Ottawa.
And Dr. Rebecca Matthew is a cardiologist and critical care medicine specialist at the University of Ottawa as well, where she's also an assistant professor in the Faculty of Medicine. So we'll start, I guess, with you, Dr. Matthew. So as a bit of background, the milrinone compared to dobutamine in treatment of cardiogenic shock trial, the original DOREMI trial in 2021, it was a big topic of discussion, at least in our fellowship, as the comparison of these two agents had really long been debated. There's the classic sort of discussion that's really set out to try to answer a question of what might be superior, or are they more or less equivalent? So this study compared milrinone to dobutamine and concluded there was no significant difference in a composite outcome. But this trial attempts to ask a more basic question: are either of these agents superior to placebo? And I think the dogma here is that inotropes, of course, are helpful in cardiogenic shock. Anecdote would tell us this, but we have no randomized control trial data to support it. And at least if you look at IABP Shock 2, as a reminder, it often happens in cardiology that we think that something is effective and it might have an improvement in mortality, and then it turns out that doesn't pan out in randomized control trials. So I guess, long-winded intro, but I'll turn to you, Dr. Matthews, and just ask if you could just talk a little bit about your motivations for running this trial and whether you encountered any ethical hurdles, since you're suggesting a placebo arm of normal saline against what is already considered standard of care, and just how you guys crafted it.
Yeah, I think so. I mean, thanks so much for the kind introduction, and obviously having Ben and I here. It's really wonderful to have this opportunity. So, that's a great summary and introduction. I couldn't have said it better myself. I think the biggest motivation for running this trial is what Dr. Hibbert actually said to me when I was a first-year cardiology resident, which is that anyone who has a vested interest in doing awesome clinical medicine should have that same passion for clinical research, because the best the best research questions really arise from what we do at the bedside as clinicians, because ultimately all the research that we do, we really want to translate that to taking care of the specific patient at the bedside and have better outcomes. So, with that being said, as you highlighted, dogma drives so many of the decisions that we make, and dogma is really hard to change. And, within critical care and cardiology and so many other areas of medicine, we have challenged dogma, what we believe to be unshakable, unquestionable, and we've proved ourselves wrong over and over again, right? So, look at paramedic, look at nice sugar, you can look at a total, you can look at CAST 1 and 2, like we've done this over and over again. You talked about IBP shock. And so, for Ben and I, when we initially set out to craft DOREMI, the first one in terms of Mil versus Dob, we wanted to start addressing that dogma, but do it in baby steps. And so we thought, to withhold inotrope completely is pretty, stressful for other people. So that's why we thought Mil versus Dob. And then once we did that trial, we felt like we had enough sort of runway and lead in order to approach this inotrope versus placebo in the early resuscitation period. And so, I think that's the second question to be answered. The third question, which I'm more interested in, is prolonging that placebo intervention for more than 12 hours. So, now you're talking about days, duration of hospitalization, and sort of really starting to answer these questions around what is the harm benefit scale, and sort of where does that end up in managing these patients. So hopefully that's a bit of an answer. I apologize, that's a bit long-winded. And then in terms of the second thing that you asked, the ethical hurdles, oh dear, there were many, not so much in terms of the actual REB and sort of process of doing ethics. I mean, that's very standardized and algorithmic, and, it just demonstrates the importance of doing a really detailed literature review before you start undertaking these types of trials. So this is where I think systematic reviews and meta-analyses are really important. Understanding the literature is really important, and going in really informed about what the body of literature is around the specific question that you're trying to ask. More interesting ethical hurdles are working with a larger group of people where everyone has, really years and years of experience and a lot of strongly formed opinions in terms of, what they want to do in caring for these patients. And so it was, a lot of buy-in, getting people on board in terms of understanding the protocol and getting comfortable with randomizing these patients. And that was just something that took time. We're lucky to work in a really supportive center. And ultimately, DOREMI 2 is going really well as well. So I'll stop there. Sorry, that was a bit long.
No, it's a great answer. Thank you.
No, that was fine. Thank you so much for that background, Dr. Matthew. Obviously those of us reading the trial don't realize you'd already, you and Dr. Hibbert had already thought of DOREMI 2 prior to conducting DOREMI 1. So thank you for that background. I'm going to now direct a question to Dr. Hibbert. And, obviously when we're thinking about how we apply our evidence to our patients, it's so important for us to think, did our patient even meet, inclusion criteria for whatever study? And so, Dr. Hibbert, my question is about inclusion and exclusion. A recent analysis from the Cardiogenic Shock Working Registry released on July 19th in JACC that arguing that stage B shock as being either hypotension or hypoperfusion, arguing there's a significant portion of patients that are normotensive with hypoperfusion and early shock. In the same paper, they showed data that 90% of stage B patients will progress to stage D or E, and state that this is a key cohort to consider. I wonder if you could talk about how you balance inclusion and exclusion with your trial, specifically not including patients who are in stage B and also excluding stage E. And this approach was obviously in contrast to the first capital DOREMI, a trial comparing milrinone to dobutamine in cardiogenic shock, which included patients with SCAI stage B to E.
Yeah, so great question. I mean, ultimately, you can design trials to kind of treat that perfect patient population, or you can design your trials to be as pragmatic as possible to kind of reflect the kind of patients that you treat. And when we set out to do DOREMI 1, so to be clear, the SCAI criteria weren't even published, right? So when we started DOREMI, we had inclusion criteria that reflected inclusion criteria from a number of shock trials, but were broadly designed to include the patients that we would want to treat with inotropes. And then as the SCAI criteria were published while we were running the trial, we adopted those criteria in a retrospective manner to the patient population to classify them. So, in DOREMI 1, which ultimately ended up being a trial of SCAI C and D, right? That was over 95% of the patient population. I had a couple patients in SCAI E and a couple patients in SCAI B. But really, what we were trying to, capture, or what the spirit of the trial was to treat those patients that we would normally treat with an inotrope. So when we were rounding them, this would be the type of patient that we came along. And obviously, the SCAI classification has completely changed the way that we talk and communicate to each other about shock patients. And I think that's a good thing, because it's really standardized some of the nomenclature around these patients. However, it's important to highlight that there's still a lot of gray in how we classify these patients. So the paper that you referred to in July 19th, I think does a great job, because it really puts more firm parameters about what classifies you as a stage B, what classifies you as a stage C. However, those are still arbitrary cutoffs. And while they're being designed to kind of predict prognosis, I'm not sure everyone that would read those would necessarily agree with those would agree with those guidelines. And even if you read the paper earlier in the year in JACC on the definitions, one of the things they defined this differentiating between SCAI-B and SCAI-C was the presence of elevated lactate. So that would be in contradiction to the later paper. So I think even in the field, these definitions are evolving. That being said, when we went to do DOREMI 2, we really wanted to, again, reflect those patients that we would normally treat with an inotrope in the day-to-day rounding in a cardiac intensive care unit. And so we felt that was best reflected in including SCAI-C and SCAI-D patients. You're absolutely right, though. SCAI-B, I think, with that paper that came out, earlier interventions in those patients, especially if that large of a cohort is progressing to SCAI-D and E, preventing the march of shock is probably going to be a therapeutic target. I mean, the reality of all of this is, these patients are going through these SCAI classifications at various phases of those shocks. So the SCAI-B shock, or the SCAI-E shock patient that you meet was SCAI-B at some point. It's just when you end up meeting them. And so, ultimately, this is all one disease. And, we felt that most people would be agreeable to treating SCAI-C and D patients with inotropes. Those are the patients that we would normally treat. And so we wanted to make the trial as pragmatic as possible. And if you look at the inclusion criteria, you have to be 18, you have to be SCAI-C or D, and you have to want to treat them with an inotrope. We excluded patients without a hospital cardiac arrest. And that is one thing that I find is very conflated in the SCAI definitions. I don't think out of hospital cardiac arrest patients should be in that cohort. They usually have a neurologic death. It's very rare that we don't resuscitate patients from their cardiogenic shock in the context of out of hospital cardiac arrest. So that adds a lot of confounding. You can't have a dynamic outflow tract obstruction because obviously we don't want to make that worse. And you can't have been on mill or dobutamine. And that's actually the number one exclusion is that, patients are transferred to us already with an inotrope on. And so, obviously the hypothesis of the study is that inotropes will facilitate resuscitation of these patients in early shock. And so if they come on an inotrope, we can't enroll them. So these are broad, inclusive inclusion criteria, very limited exclusion criteria to try to make this as pragmatic and reflective of the care that you guys provide to your patients every day.
No, that's such a great answer. And it's right. It's there are such fluid stages that, you still will capture all of the patients, just a different time, so I really appreciate, sort of the way that you answer that. I'll turn to you again, Dr. Matthew, and with just saying, so one of the interesting things that for me, as a soon-to-be minted cardiac intensivist, I guess if anybody hires me, there's always that, but is the variability in regards to how an attending will track and make adjustments to therapy. So just thinking about, the variability even in my own ICU, forget across ICUs, because obviously every institution kind of has their own, inborn processes and kind of their own ways that they do things. I know we have intensivists who will do it, but will adjust their inotropes by SWAN numbers, others to urine output and symptoms, and more esoteric lactate, things as well. So will your study, I guess, require a protocol for titration? And if so, how will you balance the various styles that some physicians would escalate? So for instance, I could imagine that, some physicians might escalate slowly or some too quickly, and each would necessarily have its problem in a randomized controlled trial. So how do you guys aim to address that, or what are your thoughts there?
Yeah, so I mean, I think that's definitely that's a really pragmatic, practical question that we had to try to answer. As you highlighted, there's really no evidence to support titrating therapy to any specific thing, right? Like, symptoms, hemodynamics. What we do, I think, generally what I've seen is really focus on markers of end organ perfusion and try to normalize that, or what we think is normal. protocol. And there's even some variability from center from that perspective. We very recently in the last month or so published a Jack Advances paper where we sort of looked at perfusion targets and cardiogenic shock. And I think one of the things we really tried to highlight was that there is not a lot of data to guide this resuscitation. And so ultimately it comes down to what your experience was as a trainee, what the people who trained you did, and what you've seen work sort of anecdotally. So I think with that as the background, we really made a point of not providing a standardized titration protocol and specific cut points and guidelines to the physicians. What we told people is, these are the common doses that are used. So we have sort of stage 1 to stage 5. So starting at 2.5 of DOB or 0.125 of mil, and then titrating up in the usual stages, 0.25, 0.375, 0.5, 2.55, 7.5, 10, because that's what we've sort of seen, at least across Ontario and Canada in terms of standardized doses. But we've essentially told the physician, you titrate the drug according to what you feel you would normally do. We wanted to make this pragmatic. We wanted to replicate clinical practice. And we really want it to be applicable to our colleagues across the country and wider, hopefully, in terms of what they can take to the bedside. So we haven't provided hemodynamic targets. We didn't provide, specific lactate cut points or urine output cut points. We've told people to do what they do in clinical practice. And I think that's the beauty of doing these pragmatic trials is, hopefully people in other centers can see their own practice reflected in what was done in the clinical trial, and it helps them take care of patients. I think what'll be interesting as we sort of move forward in terms of the work we're doing in cardiogenic shock research is seeing what targets are helpful and what targets actually correlate with hard outcomes down the road, right? Does hemodynamic guided resuscitation make a difference at 30 days? Can we use lactate, clearly as a marker in terms of resuscitation and change outcomes down the road? I think that is a huge area of shock that needs to be explored more, something that we're interested in exploring more. Right now, we just don't have the data to guide that. And so that's what we tried to replicate in our protocol. I don't know if Ben wants to add anything to that or if he sort of feels like that aligned.
No, I agree with you totally. And I think it also speaks to the importance of blinding in a trial like this. Because obviously if people knew the treatment assignments, then they might behave differently. And so while it makes, I'll say it makes a lot of cardiac intensivists feel uncomfortable to know if their patient's on an inotropes, it just speaks volumes to, how I think patients would get treated differently if people knew. And so, that's why we think it's incredibly important, one, to have a placebo-controlled trial, and two, to blind, to make sure that ultimately we're able to ascertain whether or not the inotrope is responsible. But Rebecca's bang on. We really want this to reflect clinical practice, like people treat their patients day to day.
So I'm going to take us to talking about lactate, which came up in the answers to the last question. But Dr. Hibber, I have a clinic preceptor who always says that lactate is the troponin of the non-cardiac organs, and not to the fact that lactate often is a reflection of recent but not current malperfusion. Just wanted to get your thoughts on what you think about the composite outcome of lactate being cleared within 6 hours versus 12 or even 24. Many patients even with restored perfusion continue to have elevated lactates for hours to days. I'm curious how you decided on lactate clearing within 6 hours and what it might mean for the results if both placebo and treatment arm have either A, a high degree of continued elevated lactates, or B, crossover to receiving mechanical circulatory support.
Yeah, great question. So this endpoint is born out of one part of people's lack of comfort with a placebo control. And secondly, it's evidence-based. So, when we were designing this study, both the duration of treatment as well as the bailouts, had to be in place to make sure that people felt comfortable randomizing their patients to a plausibility of placebo. And so if patients end up on very high vasopressor doses, we're unable to maintain their MAP, if we're unable to successfully resuscitate them, if something bad happens and they have cardiac arrest, they're out of the trial and they bail out to open label. And this is commonly done in trials of vasopressors and inotropes, because otherwise no one would ever enroll a patient if we just persisted until they had a bad outcome. The nice thing is with this trial is we essentially have 192 patients in the treatment arm from the DOREMI 1 trial. And so Jeff Marbach, who actually trained with us and is starting at OHSU as a cardiac intensivist, he's a great person to work with if you get a chance. He actually wrote a paper in the Journal of the American Heart Association, which is a sub-analysis of the DOREMI trial. So we looked at what were predictors of mortality and specifically looked at lactate clearance. And lactate clearance at all time points was a predictor of mortality. And actually, when we looked at early lactate clearance, we had 8 hours in that paper. It was the strongest predictor of mortality. It was stronger than their SCAI class. It was stronger than their age, whether they were an AMI or non-AMI heart failure or non-AMI cardiogenic shock presentation. It had an odds ratio of 4 if you hadn't cleared your lactate by 8 hours. And so we elected to pick that because we felt that if by 6 hours patients hadn't cleared their lactate, we anticipate more than half the patients will clear their lactate by 6 hours based on the data that we have in the treatment arm. If they hadn't by 6 hours, it was such a strong prognostic marker of adverse outcome that we felt it would be important to bail them out to open label, and then the treating team can decide what to do. Again, ultimately, we'll have those rates in between the groups. And we look at this all the time in the trial, blinded data, but we'll look at it and we'll know the rates. And if ultimately the rate of an individual endpoint is driving it because all of the patients have an elevated lactate, then we'll have to review that as the trial is conducted. I can tell you so far we've enrolled over 10% of the trial. It's going extremely well. And a lot of the patients aren't endpointing. And I've looked after a lot of these patients myself, and it's fascinating how many of these patients get better, knowing that half of them are getting saline. And so I think there's just going to be a lot to learn from this first placebo controlled trial in cardiogenic shock. But it was for basically investigator comfort or for treatment team comfort, and it's evidence-based. We know that if they haven't been successfully resuscitated, they're out. As for your last point, crossing over to mechanical circulatory support, I anticipate this to be extremely low. So in the first, while we anticipate having centers in the United States, this will be predominantly Canadian-based trial. We don't use a lot of MCS, and I must admit, we're pretty hawkish on the MCS data in Canada, and so I don't anticipate that you're going to see a lot of patients early in their shock crossing over to MCS. When our patients do, usually they've been flogged pretty hard with vasopressors and inotropes before they cross over, and most of the patients will be out of that 12-hour window before they get crossed over to MCS.
That's great. One of the comments you made about, you already have 192 patients, cohort of patients to look at from, the original DOREMI trial, really segues nicely into my next question, which I'll direct to you, Dr. Matthew, which is that one of the pitfalls, or I guess potential pitfalls, I don't know that we see it all that commonly, but of dobutamine would be in either ischemic myocardium, where you could have worsening demand ischemia and where dobutamine might actually make things worse, or just in somebody who is, prone to ventricular arrhythmias, and dobutamine could stir up arrhythmias in otherwise irritable myocardium. We've talked about how out of hospital cardiac arrest patients are excluded, but my understanding, at least, and please correct me if I'm wrong, is that AMI, cardiogenic shock, is not excluded. So will these patients include, will your the patients in the study include post-MI patients? And if not, if not, why? And then for anyone coming in with like heart failure, cardiogenic shock, I'm thinking specifically of like a patient who's coming in with a new first presentation of heart failure that could be ischemic, we just don't know. Is there, have you guys, are you leaving it up to providers, or are you in any way looking to assess whether they have a degree of coronary artery disease that could be driving the presentation? So I'll ask you that.
Yeah, so awesome question. And, it's always great to hear questions that us as a group of investigators discussed at length when we were putting the trial together, because it makes us feel like, okay, we're hitting on practical aspects that people are going to be interested in. So we talked about this a lot while we were running the first DOREMI, and definitely while we were prepping for DOREMI 2. And so we actually have sub-randomization by AMI-associated cardiogenic shock versus non-AMI-associated cardiogenic shock. So hopefully that answers answers your first question, that we absolutely agree. These are different populations. They have different morbidity and mortality. They're different from a prognostic perspective. And I think research is really being focused on different phenotypes of and etiologies of shock, because they are different. And so we need to sort of explore them, understanding those differences. So we've tried to address that with DOREMI 2 as best as we can. The other thing that's sort of interesting is one of Dr. Hibbert's MD PhD students actually finished his PhD and his MD. He's in residency now. Dr. Jung actually did a sub paper, which is already being published, actually looking at kind of AMI versus non-AMI presentations in the original cohort. And we actually looked at the effects of Mill versus Dobb, and we saw no difference in the AMI cohort. So we did actually try to look at that in retrospect from DOREMI. And certainly in DOREMI 2, in the AMI patient who's randomized, absolutely the physician at the bedside, if they're nervous about dobutamine, totally can pick milrinone as their inotrope that they want the patient to, versus placebo, depending on what they're randomized to. But that is up to the physician at the bedside. So, we never want to do anything to obstruct or impede what the physician wants to do. And we completely understand that there is that nervousness about ischemic myocardium and tachyarrhythmias and, worsening ischemia. So that's why we've crafted DOREMI 2 in the way that we did to try to address those concerns. There's so many things about DOREMI 2 that I think set ourselves up for even more trials coming as a result of that trial. I think that's sort of the best research, right? Where you're in the middle of doing a project or a clinical trial and you can already see the road ahead and the next kind of 2 to 3 trials down the road. So we'll kind of see what things show, but we definitely tried to address that with DOREMI 2. Yeah.
So for our final question, I'll ask both you, Dr. Hibbert and Dr. Matthew, to give us an update. It sounds like you've already started enrolled 10% of the patients, and we're curious to get an idea when we can expect to see results, and also if you have any predictions on what we might find.
Yeah, no, the trial's been, solidly exceeding expectations. Now, we've only opened up 2 sites. We're going to be opening up more sites in the near future. We've enrolled 10% of the cohort in a little over 5 months, and that's including the first month when you're rolling the trial out. So, I think pragmatically, this is going to take us 30 to 40 months to complete. So probably 3 years to finish this. This trial is larger, so it's mid 300s. So it's going to be not quite double the size of the original DOREMI trial. But that being said, we're going to have more sites on board. More people are, paying attention to this field of research now. And so I think we're going to get more people interested in enrolling. In terms of predictions, if you had to ask me when we started, my bias was that I thought inotropes would be helpful in the early resuscitation. Lactate clearance. We all have that experience of starting milrinone or dobutamine, the lactate clears, we pat ourselves on the back and we go about rounding. What's interesting, since I've been looking after randomized patients, is a lot of the patients are getting better. And I know half those patients are on placebo. And so it does make me wonder if whether, optimizing the patient's volume status, giving them a little bit of hemodynamic support with a vasopressor might be the right thing. What's also interesting is when we looked at DOREMI 1, a lot of critical events happen in the first day. It's not surprising patients come to us very sick. And we know these medications have side effects. They do induce tachyarrhythmias. And nothing is worse for a sick heart than a resuscitation. And so I think it'll be really fascinating to see, are we perhaps harming patients by initiating these therapies that they don't necessarily need? And I think it'll open the door, if it is negative, to either a more prolonged therapy, or maybe we've just been doing it wrong all along. We do need to implement MCS earlier and stop fiddling around with the drugs and support them up front and not get some of these toxicities. So all of that to say is, even in the first 40 patients, what I think is going to happen is changing, and I think that just speaks to how little we know about cardiac intensive care. I'm an interventional cardiologist. I know an awful lot because we have great evidence bases for some of the things we do in the cath lab. And then when I change rooms and I go and I work on our cardiac intensive care unit, I sit there and then we lick our finger, we put it in the air, and we do what we always did. And so I think young people like you who are like fully trained in cardiac ICU and eat, breathe, and sleep this stuff are going to change this field and going to move mortality, because we're going to get rid of the things that don't work and we're going to start implementing these things that work. So I don't know, is the short answer.
Well, no, credit to you both for changing the field and for all that you guys have done and for taking the time out this evening. This has been a real pleasure, and we're just so thankful.
Thank you very much.
Yeah, it was great to chat, and super exciting to see other cardiac ICU people coming through. This is a really, really exciting time for our field, and we really get to kind of shape it and make it our own. So it's just awesome.
Thank you so much. It was so nice meeting the both of you.
Bye.